A very good morning to Prof. Muhammad and Dr. Farida. We from Group 3B will be presenting a case of meningitis. This is a case of 65 years old male. He presented chief complaint of headache, fever, shaking, chills, malaise and neck stiffness. He smoked 3 packs of cigarettes per day for the past 15 years. He works as a truck driver. History of presenting illness. He lost 7 kg over past few months and experienced ear pain and mild fever a week before. He also developed fever and headache for 4 days. The headache was associated with inability to tolerate loud noises and bright light. 2 weeks before, he was admitted for 5 days due to poor blood sugar control. Past medical history. Patient had diabetes mellitus for 5 years, mild hypertension, bronchitis, appendicitis, hemorrhoids, and fractured femur and splenic injury. Patient was also on medications such as tablet metformin 1000 mg, tablet glibenclamide 5 mg, tablet metoprolol 50 mg, and tablet theophylline 250 mg.
Moving on to the next part, the evidence to support the diagnosis are risk factors, signs and symptoms, lab results, and imaging. The risk factor for the development of meningitis in this patient are extremes of age, medical condition which is diabetes mellitus, smoking, as well as splenic injury. The signs and symptoms suggestive of meningitis manifest by this patient are fever, stiff neck, headache, chills, malaise, photophobia, and confusion. Next, from the lumbar puncture sample, it was found that there are elevated white blood cell count, increased protein and lactate levels, as well as decreased glucose level. These results are suggestive of bacterial meningitis. It was also found that neutrophil level has increased up to 90%, hence supporting that this patient has bacterial meningitis. From the CT scan, it was found that there is ventriculomegaly and succal effacement, which are indicative of bacterial meningitis.
Potential drug-related problems. The first one, compliance to medication or ineffective dosing or therapy. This is because the patient has uncontrolled blood sugar level and uncontrolled blood pressure. Therefore, pharmacy needs to assess patient compliance to medication and counsel the patient accordingly. Second, the pharmacist may consult doctor in case there is in need of increasing dose of therapy or using combination therapy. Second, drug-drug interaction between anti-diabetic agent and beta blocker which can mask hypoglycemic event. Therefore, pharmacists need to close monitor for signs and symptoms of hypoglycemia. The last one is drug-tobacco interaction, which is the major one, as smoking will increase metabolism of theophylline and can cause subtherapeutic level of theophylline. Therefore, pharmacists may adjust maintenance dose up to 0.4 to 0.6 mg per kg per hour, and after 3 days of dose adjustment, pharmacists need to measure the serum concentration, and once maintenance dose is established, the serum level of theophylline can be measured 6 to 12 months.
Next, I will talk about treatment. For the bacterial meningitis, the empirical therapy for the preferred treatment is ceftriaxone 2 gram IV every 12 hours or cefotaxime 2 gram IV every 6 hours, or the alternative is chloramphenicol 1 gram IV every 6 hours. However, patient had allergy towards penicillin, and this might cause hypersensitivity towards cephalosporin group, which is ceftriaxone and cefotaxime. Hence, chloramphenicol is preferred in this patient. Next, dexamethasone 10 mg IV every 6 hours is given to blunt the inflammatory response secondary to the bacteriolysis. It should be continued for 4 days if gram stains and cultures consistent with Streptococcus pneumonia, and it should be discontinued if not Streptococcus pneumonia or bacterial meningitis is subsequently not to be present. For the fever, paracetamol 1 gram every 4 to 6 hours should be given. For the empirical therapy, it should be continued until the culture and sensitivity result is obtained before narrowing down the selection of antibiotic use.
Next, pharmacists optimize the antibiotic therapy by ensuring the appropriateness of the antibiotic via the type, dosing regimen, route of administration, and the duration given. Pharmacists also monitor the patient profile to ensure the safety and effectiveness of the antibiotic to improve treatment outcome and avoid adverse events. Under intervention, initiate the isolation therapy with narrower spectrum antibiotic once CNS result is available to avoid resistance. Switch the IV route antibiotics to oral dosage form once patient is clinically stable. The other pharmacist intervention are educate patient to join smoking cessation as tobacco use increase risk of infection and worsen is a health condition. Next, assess patient adherence and the dose of diabetic and hypertension drugs as the RBS and BP level are above the normal range. Pharmacists also may plan for the dose adjustment to prevent toxicity as the high serum creatinine shows the sign of renal impairment in this patient. Finally, patient counsel on lifestyle modification with good diet and exercise are essential.
Finally, monitoring parameters. For efficacy, repeat cerebral spinal fluid exam. Check WBC, CSF pressure, protein level, glucose level, and lactate level. Next, monitor vital signs such as BP, temperature, heart rate, respiratory rate. Next, monitor clinical improvement of signs and symptoms of the meningitis. Next, monitor culture and sensitivity tests. And finally, monitor patient overall well-being. For safety, monitor plasma concentration level, hepatic and renal function periodically. Monitor CBC with the differential at baseline and every 2 days during the treatment. Monitor hypersensitivity reaction and finally monitor for hydrocephalus.